The Arthritis Research Coalition is proud to present these ARC Talks throughout the year in an effort to share the latest discoveries in research, as well as cover topics of interest for those individuals impacted by arthritis and autoimmune disease. Our mission is to improve the quality of life of people living with arthritis through funding of research and education. Our vision is to defeat arthritis and champion wellness. The Arthritis Research Coalition funds leading research on arthritis and related conditions at Stanford University and University of California, San Francisco. We serve the Monterey and San Francisco Bay Area regions through research support and health education programs. We are very proud to say that over the past 4 years, we've been able to contribute over $1 million so far to help fund research. With that, I'd like to introduce Dr. Michelle D. Fiore. She is a rheumatologist who practices at Sutter Health in Palo Alto. She did her medical training at Chicago Medical School and then spent 6 years at UCI, completing her internal medicine residency and rheumatology fellowship. She grew up in the Bay Area and is happy to provide care in the area where she was raised. With that, thank you so much, Dr. D. Fiore.
Thank you for the nice introduction. And yeah, I'm happy to give some information tonight. My talk is titled, But I'm So Young, How Could I Have Arthritis? So, kind of talking a little bit of what Anne was saying, it's really important to one, continue to have research to help our patients, but two, recognizing the disease in young patients because starting treatment early can help us control the disease and prevent long-term damage from arthritis in these patients. And I'm lucky to practice in an area that has a lot of options for this, but it's also important for you to know what's going on with your joints so you can discuss it with your primary care doctor and ultimately a rheumatologist as well. So hopefully this can be helpful for you or a loved one that has arthritis symptoms, and we'll go from there. So I just wanted to start generally. What is arthritis? It's joint inflammation that causes swelling and tenderness of one or more joints. So this is a very simplified version of a joint. So you have the two ends of the bone, and then this kind of light pink area is the cartilage that cushions it. And a lot of our joints has this capsule around it with some fluid there as well. And day to day, we don't really feel the fluid in our joints. It's very minimal. But when there is arthritis, there can be a lot of swelling at those joints and the fluid increases. And typically when we think of arthritis, we think about the joints that we use all the time, our knees, hands, and our back can develop arthritis as well because it's supporting us throughout the day and we use it more than we think. So what happens in arthritis is that there's some inflammation in this capsule, and that can lead to the degradation of the cartilage. So typically when, in older patients, that's the wear and tear. We're using our knees too much, our hips. It's just two ends of the bone wearing on each other. That cartilage gets, worn down. There can be some bone spurs, and the bone rubs together, and there's pain. So this is a picture of a knee, and I know that a lot of people don't look like at X-rays every day like I do, but we can kind of see here with that schematic of the previous picture, this knee joint, this area right here where there's a gap, that's where the cartilage lives. But on this side, it's bone on bone because this person has been using their knee for a long time. So osteoarthritis is the wear and tear arthritis that comes with age. And I tell my patients who are older, it's one of those privilege of aging. Hopefully someday I'll get to experience joint pain with osteoarthritis because we're just living our lives and our body takes the wear and tear. And like I said before, common joints, hands, spine, hips, and knees, areas that we use quite frequently. But that's all well and good. I think that's the type of arthritis that we think about. But today, oopsies, we are talking about how can this happen in younger patients. And it's not because of the overuse, it's not because of the wear and tear. There's something else going on in your body that can cause inflammation in that joint capsule. So typically it's because of an underlying autoimmune disease. And I think a lot of us know the general concept of that, but I just wanted to give a little schematic of that as well. So, our immune system has antibodies floating around and they are there to detect things that should not be there. So viruses, bacteria, these Y-shaped structures are how antibodies are kind of structured. So that's how we see them in this picture. And they will float around. They might encounter a virus and it sets off the immune system to get rid of that. But in patients with autoimmune conditions, the immune system has made a mistake and they've made antibodies that actually are to our own self. And particularly patients with arthritis, it can be to that joint and the joint capsule, and it can set off that cascade of inflammation, causing a lot of inflammation. The cartilage gets deteriorated, and that same process happens, but it's nothing that the person did, it's coming from their immune system. And autoimmune disease are quite prevalent. So these are some common, I shouldn't say common, but some autoimmune diseases that you might have heard of: lupus, psoriasis, type 1 diabetes, Hashimoto's disease, multiple sclerosis, rheumatoid arthritis, Crohn's disease. So it can affect a lot of different organ systems. So Hashimoto's disease is an example. It's very common. It's antibodies to the thyroid, and then the thyroid doesn't work as properly. It doesn't produce thyroid hormones, and then patients need to be on supplementation for that. I just wanted to share that because some patients, when they come to see me, they're like, well, you're an autoimmune doctor, but autoimmune diseases can affect a lot of different organs, and sometimes a different specialist might need to evaluate that patient. So something like multiple sclerosis, a neurologist is much more apt to evaluate a patient for MS than I am. I don't know as much of that disease. So what is a rheumatologist? It's a doctor that specializes in autoimmune diseases that affect primarily the joints, soft tissues, and that means like the skin, muscle, the vasculature, cartilage, everything that goes around the joint as well. So things that we do, I get this question a lot. Sometimes when patients are referred to me, they're like, I don't even know what a rheumatologist is. So just taking a moment to explain that. When a patient comes to me, I listen to what's going on, kind of gather a detailed history of the symptoms when they started, what's going on. And then we do a joint exam. So that I'm detecting the fluid in their fingers, making sure the range of motion is all okay. And sometimes we prescribe specialized medications for these autoimmune conditions. We can sometimes perform joint injections where say a knee is really swollen and I can take some fluid out to analyze it to see if that can help me diagnose a patient's arthritis and also provide relief to the patient because the knee swelling can be painful. And we do work with a lot of other specialists to coordinate care. Some of our autoimmune conditions that we'll talk about affect other organs, and we coordinate care together to, take the best care of our patients. So today I wanted to touch on 3 big topics. I could probably spend an hour on or more on each of these topics, but my goal is to give you the key elements of these conditions, to be aware of them in yourself and to communicate with your primary doctor what testing might be helpful. So when you get to a rheumatologist, that visit is very fruitful and you can get care quickly. So the first one is rheumatoid arthritis. The next one is ankylosing spondylitis. And I'll also discuss psoriatic arthritis during that time. And the last one is lupus. So rheumatoid arthritis is something that we commonly see in clinic. Symptoms start between the age of 30 to 50 years old on average. It can present later, but typically it is in younger patients. Symptoms. Usually the patient is having more than 6 weeks of joint pain. I know that's a long time when patients are really in pain, but more than 6 weeks is a cutoff that things are persistent and staying around. And I use the term inflammatory joint pain, which is kind of a medical jargon, but I wanted to describe what that is. It can be very helpful for you. Um, Pain that is worse in the morning, and there's usually stiffness for more than an hour. So my patients, usually it's like I wake up in the morning, it's just hard for me to even close my hands, grabbing that coffee cup. It's painful. And it can last, hours. And then as the day goes on, things get better. And typically, movement helps. Once I get my joints moving, then things are better. They might not be perfect, but things improve. And so I kind of think of the Tin Man. Each joint just feels really stiff. You need to move and get oiled up to get that inflammation away, and things improve. It typically affects the small joints first. So the fingers, wrist, ankles, and feet. You can see in this picture here, this person's knuckles here are swollen. And rheumatoid arthritis also likes to affect these knuckles as well. So they're called the MCP joints. So another thing to think about is that it's on both sides of the body. So not just, oh, this one finger hurts on this side. It's this one and this side, and maybe both wrists and some toes. I would say more commonly it happens in the hands than the feet, but it's both sides of the body. A lot of rheumatology is patterns, so this is important. If it's on both sides, it raises our suspicion. Other things to think about is that it runs in families. If you have a relative that has rheumatoid arthritis, it doesn't absolutely mean that you will get it. Or if you're diagnosed and have children, it does not absolutely mean that they will have it either, but there's a higher chance of them developing it. Females are affected more than males. And when the disease starts, some people can have a lot of fatigue with it and even low-grade fevers. Sometimes we think there might be an infection going on. Things that you can do to help accelerate a diagnosis would be talking to your primary care doctor about getting some blood work done. There's 2 blood tests that we check for rheumatoid arthritis called the RF and the CCP, rheumatoid factor and CCP. And also, there's some inflammation markers in the blood that can be helpful. They're called ESR and CRP. Some people might be familiar with these, but a lot of acronyms, I apologize. But those blood tests, if they're abnormal, definitely means that you should be talking to a rheumatologist to get further evaluation. Oops. And then x-rays can be helpful as well. If the person's hands are swollen, or if they're starting to have misalignment or inability to make a fist, sometimes we can see changes on the x-ray that are in a pattern that as a rheumatologist, I can detect rheumatoid arthritis in the patient as well. So having x-rays are very helpful as well. The next disease that I wanted to talk about is ankylosing spondylitis. So this typically starts in patients less than 40 years old. And the low back is stiffness. So it's a slow onset of back pain we use about 3 months. So it's not like, oh, I lift something at work and I really threw out my back and now things hurt. It's this creeping, oh, I kind of was stiff, but maybe it'll go away. No, and it lingers and gets worse. It improves with movement, just like rheumatoid arthritis. So sometimes patients tell me, like, I have to get up in the morning and I go for a run, or I go for a walk, or do yoga, because that movement really helps the stiffness in the low back. Laying down and getting rest does not help. Sometimes prolonged sitting, like I have patients tell me, I tried to take a road trip to Tahoe, and I just that sitting and for a long time, it really made things worse. So rest actually does not improve the stiffness. And sometimes the back pain will wake them up early in the morning. It can be 4 or 5 o'clock. They're already stiff and they need to get out of bed and start their day and warm up. And unfortunately, for some of both RA and this condition, like patients are like, my morning routine is so much longer because I'm so stiff in the morning. Oops, let me go back. This x-ray here is of the joint that is most commonly affected in ankylosing spondylitis. It's called the sacroiliac joint. And so your sacrum is this upside down triangle here, your tailbone. And where it attaches to the hip is the sacroiliac joint. And again, I know that the arrow, we call it the arrow sign, can let you know where there's an abnormality, but there tends to be inflammation at this joint, and that is what's causing the low back pain and stiffness. So a lot of times when patients have low back pain, it's in the lumbar area, that very end of the spine, that's up a little bit higher. You can tell these parts of the bone is kind of that like part of your hip you can feel on the side, the ridge of the hips. And so if you go back, it's lower in that area. This condition affects men more than women. So typically autoimmune diseases are thought to be in women more than men, but this condition is men more than women. And they can have other features. So sometimes there can be eye inflammation with a red, painful eye that can cause vision blurriness. And this is something that is very a lot of discomfort, and patients tend to go to urgent care or the emergency department. It's not like dry eye or itchy eye. It's something that you would be seeking medical care because it's very uncomfortable. Is something called uveitis, and that can be related to ankylosing spondylitis. Another thing is that they can get tendon insertion pain. So these are some areas that are common. So this is your Achilles tendon at the base of the heel. And right at that area where it inserts, it can be very painful. Sometimes when patients are, playing pickleball or doing a lot of activity, the Achilles can be painful up here. This is right where it inserts. And same with the plantar fascia. This is someone's elbow. And so this is tennis elbow right on the end here. And this would be happening like not something repetitive like you do that would provoke tennis elbow. It's just like a lot of point tenderness and pain that can develop. Another condition, I don't have a picture on here, but it's on this list, is autoimmune gut problems. So if someone is diagnosed with Crohn's disease or ulcerative colitis, they can have some of these other joint and eye issues. This is a picture of psoriasis. So psoriasis is a red flaky rash that typically presents. This is kind of patchy all over the front of the leg. A lot of times it's in a big patch right here over the knee. It can be here on the elbows or in the scalp. It likes to hide in crevices like the belly button, the butt crack, and the groin. So patients with psoriasis, they're in this same family of this ankylosing spondylitis. And patients with psoriasis can develop arthritis. It sometimes is confused with rheumatoid arthritis because it can affect the hands. But they have these other features of the back pain, tendon insertion pain, and something else, wrong way, something else called dactylitis or sausage digit. So this can happen in a finger or a toe. You can see in this person, this third toe here and the fourth toe here, it's really plump and swollen. That's called sausage digit, and very classic for psoriatic arthritis and sometimes patients with ankylosing spondylitis. And I wanted to talk, I don't have a separate slide, but I wanted to talk a little bit about psoriatic arthritis. So patients with psoriasis have a 15 to 30% chance of developing an arthritis. And most commonly, It presents 7 to 8 years after someone has had psoriasis. But it also, in 15% of patients, can happen at the same time as they have their psoriasis. So the skin and the joint pain present at the same time. And another 15%, they actually get the arthritis first. And so it's kind of confusing. It's even more mysterious because it's like looking like psoriatic arthritis, but there's no rash. So that's when it takes a evaluation by a rheumatologist to really go through everything and look for these subtle features to diagnose the patient. Um, so things that your primary care doctor can do for ankylosing spondylitis specifically is to get that x-ray of the sacroiliac joint and order a blood test called the HLA-B27 that is very specific in patients with ankylosing spondylitis. The next condition that I wanted to talk about is lupus, which is pretty challenging because it can present in a lot of different ways in patients. So the majority of patients present from the ages of 16 to 55 years old. It is seen more in Asian, African American, and Hispanic individuals and can be more aggressive in these patients. It is seen in females much more than males, like I think up to 11 times more in females than males. Oopsies. And the symptoms can vary quite frequently between patients. So, and there's a lot of different features. So, how lupus affects the body, there can be hair loss, oral ulcers, joint inflammation, rashes, intolerance to sun exposure, fevers. And so, not every lupus patient will have all of these symptoms, but they might have some of them. So I mentioned here arthritis, skin problems, and fatigue, and some of them can have organ involvement. So that's when I was saying that it's important for us to work with other specialties. Like sometimes it can affect the kidneys, which is super important. We do a lot of screening to see if the kidneys are affected in these patients. And then sometimes they can have decreased blood counts like anemia, low white counts, low platelets, and rarely they can have seizures. Other things to think about for lupus, the lupus diagnosis requires the patient to have both symptoms and abnormal blood test. So I say that because the blood test can be a little bit tricky. The first test that we get is called an ANA, and it is asking, does your body make antibodies to yourself? That test alone is not diagnostic for lupus. It actually can be seen in 5% of the general population. And in healthy individuals. So you have to have the ANA plus specific lupus symptoms, and maybe some anemia or low white count with that. So that's why it kind of takes a little bit more. It gets pretty confusing because patients have some of these symptoms and then a positive ANA, but they don't fully meet criteria of lupus. Lupus can run in families. Same thing. It does not mean if you have a family member with lupus, you will develop it, but there's a higher chance. And so for your primary care doctor, it is to get an ANA test, and there's some other specific antibody testing that can be done as well, looking for anemia, low blood counts like low white count or platelets, and looking at your kidney function. If the patient does have bad rashes, it is important sometimes for, even as a rheumatologist, to use my dermatology colleague to identify if this is a specific rash of lupus. Sometimes a biopsy can be needed to make the diagnosis. So when should you ask for a rheumatology referral? Especially if you have red, hot, swollen joints that are not improving with anti-inflammatories. And if they're persisting more than 6 weeks, definitely that's not something that is normal. Morning stiffness for more than an hour in the low back, hands, wrist, and feet. If you're having that prolonged stiffness. your joint pain started with rashes that can make us think about lupus or psoriasis, psoriatic arthritis. And then if you have any abnormal blood tests that are concerning for autoimmune condition, it is nice to talk to a rheumatologist because it can be confusing at times with some of these, especially in diseases like lupus. It can get tricky. I wanted to just briefly talk about some other conditions that can happen in young patients that are not part of an autoimmune condition. So I'm not sure if many of you have heard of fibromyalgia. It's a pain amplification syndrome that can cause brain fog, post-exertional fatigue, poor sleep, and diffuse pain. Sometimes patients feel like pain from the top of their head to the tip of their toes. And sometimes it gets confusing. Is this something autoimmune or inflamed joints? And your primary care doctor can help with that as well. This picture shows some tender points that are very exquisitely tender for fibromyalgia patients. So that's one thing that gets confused for autoimmune conditions. The other thing is that patients can be hypermobile. So this is something called the Baton score, and patients have hyperflexible joints. They might have been double jointed their whole life. I actually have some hypermobility too. Luckily for me, it doesn't cause me diffuse pain, but for some patient, that very hypermobile joint and flexibility causes stress on the area and a lot of pain. And lastly, I just wanted to mention tendonitis because we're doing things on our computer. We're doing repetitive motions. We're sitting in certain ways, different things. So tendonitis is not autoimmune, but it can be inflammation of some of those tendons around the joints that can be causing pain. Lastly, I wanted to mention some good resources. The internet can be a scary place if you think you have an autoimmune condition, and not everything is accurate, or it can lead you down the wrong path, and it can cause a lot of anxiety for patients. So the American College of Rheumatology is our kind of national society and has a lot of great information. Obviously, ARC. I'm really glad that you found this resource and joined the talk, and I hope that you continue to listen to the talks that they provide. There's a lot of information as well. The Arthritis Foundation has some good information. And then this Airlos Download Society has some information about that hypermobile joints, and I think it has a lot of good information about that as well. I do get a lot of questions in the office about diet, anti-inflammatory diet, autoimmune protocol, and I think there might be some questions on that I'm happy to answer. Again, just to kind of direct to a resource that I know and trust. Micah Yu and I went to medical school together, and he did extra training in alternative medicine and nutrition, and his practice is very focused on diet. He does not even know that I'm mentioning his name, but he is, I think, really on TikTok and Instagram, and he's on all the sources and just actually gives a lot of information about rheumatological conditions as well. So he is a good resource. And there is like the lupus dietitian I have met at some conferences, and she has some resources as well. Her first name's Tanya. I didn't put her information on there. I should have. But that is a good resource to look about what things in your diet can be helpful, and what to avoid. And I think that's all I have for now. I really appreciate your time. And like I said, I could spend so much more time on each of these diseases and even more. So I apologize if I didn't go into as much depth if you're hoping, but I'm happy to take some questions to answer anything that you were hoping to get from this talk.
And do you want me to read the questions out loud here that are in the discussion?
Sure, that'd be great. Thank you, Barbara.
Okay, so Dr. Michelle, the first one is, I heard the motto of arthritis is keep moving. Does this simply ease the stiffness and inflammation, or does it actually help to slow the disease?
Yeah, I use the term use but don't abuse. And
Mhm.
so very similar thought process. So it is, especially with that morning stiffness, it helps with the inflammation to go away. So gentle movement can help. And it doesn't do anything for initially in that, really acute phase when people are diagnosed, especially at that point, it doesn't do anything to prevent further disease damage, but it will help with symptoms as well. And as you know, things like rheumatoid arthritis are chronic diseases. So we think long term, it is helpful to keep moving because it also strengthens the muscles around the joint and makes it the stability of the joint, you know, better. So I think it's a little bit, just exercise itself is not proven to say, oh, this is going to prevent your disease from worsening. But I think helps for symptoms and overall is puts the patients in a better position to keep their joints healthy.
Okay, great. Thank you. The second question is, does limiting your sugar in your diet make a difference to help decrease pain from inflammation connected to with PSA?
With PSA. Yeah, so great question. I don't think that we're there yet specifically to know which diet modifications will help with which disease entities. So, for example, I would love to be able to give my patient a handout of saying, this is the psoriatic arthritis diet, and this is the lupus diet. And I really hope we get there during my career. And I think that there's a lot of research going on about that. What I tell patients is that refined sugars are thought to be pro-inflammatory, and for some patients, it really does make a difference in their symptoms of having pain. So eliminating that and minimizing it can be helpful. But I can't say specifically for psoriatic arthritis, like, that's as much as we know right now, but I think it can be helpful for some patients.
Okay, and then another question, is gout a form of arthritis?
Oh, good question. Gout can lead to arthritis. So, gout is um, a very acute onset of joint inflammation. So, there's too much uric acid in the person's body. It precipitates out of the blood and causes crystals in that joint capsule, and it's very, very painful. And there's acute inflammation that we try to manage and long term manage their diet to prevent further gout attacks. But if those attacks keep on happening, keep on happening, keep on happening, there's more inflammation in that joint. And just like I was in that picture, then that can affect the cartilage and cause erosions into the joint and can cause arthritis. So it's best to do diet modifications. And if your uric acid is too high, be on allopurinol or another urate lowering medication to prevent recurrent attacks. And so you don't develop long-term arthritis.
Okay, that is all the questions in the chat box. If anybody has any other questions, feel free to unmute yourself and ask away or type them in the chat and I'll read those too.
Yeah, and if there's something, like I said, if there was something that you were hoping to hear at this talk that you didn't, or suggestions for further talks, I'm very willing to hear that because I want to educate everyone and give you the information that you need. So I'm all ears.
I think another question that I have, this is Barbara again. A question that I have is, when should you go to the doctor? How do you know if it's not just a normal ache and pain versus, oh my gosh, could this be something?
Yeah. No, I understand. Because sometimes and it's so hard to get access to go to the doctor, and like sometimes I feel like it's threading the needle of like, should I let them know because I don't know where things are happening. But definitely if you're waking up with joint pain and it's more than an hour, and if there's any restriction like in your ability to make a fist or your mobility, and sometimes I tell patients like the swelling, sometimes people say, I don't really know if it's swollen. I'm not, I don't know. I feel like they're swollen, but then I examine it. I'm like, no, there's no swelling here. It's a good thing, like a barometer, like if your loved one is like, what's wrong with your finger, or like visible, warm, swollen joints, that's something that needs to be evaluated. Achiness and stiffness are, might be a little bit more subjective, but if there's swelling of your joint, that should be evaluated by your doctors.
Okay.
All right. Well, hopefully, if anyone does have any questions, please feel free to write them in the chat. Dr. Fiore, thank you so much for being here with us today and sharing your expertise as a practicing rheumatologist. I know we're very confident the knowledge and information you presented today will definitely help those impacted by arthritis and autoimmune disease. We'd like to thank everyone for attending today's ARC Talk, and again, we hope you'll consider attending future ARC Talks in 2026. We also hope you'll consider attending our Run Rudolph Run event, which is a 5K, 1K race, which will be taking place on Saturday, December 13th. That's at Lovers Point in Pacific Grove, and that's a fun, festive holiday event with proceeds going directly towards funding research. A link to our flyer is posted in the chat. And if you'd ever like to become involved with the Arthritis Research Coalition by volunteering, becoming a board member, donating, or becoming part of joining our mailing list, please feel free to join. There'll be a link posted in the chat as well, or there's also a QR code for direct donations. We also hope you'll consider following us on Instagram and or Facebook. And again, I'd like to thank Dr. Michelle D. Fiore for giving such an informative talk today. We appreciate knowing dedicated, caring doctors like you continue to care for those with arthritis and autoimmune disease. So thank you. And thank you also to Dr. Barbara Bartels, fellow ARC board member, as well as Deborah Roberts, our administrative assistant, for all their support in helping host today's meeting. So again, we thank everyone for attending today's event. If you ever have any questions or would like to reach out, please reach out through our ARC website. We do monitor our questions and try to get back to people as soon as possible. So we always want to be a resource for anyone who's suffering with arthritis or any autoimmune diseases. So thank you, everyone. We really appreciate your attendance today.
And I just want to say thank you to ARC. And I always mention it to patients, the research is super impactful, and I can let them know that this group is funding research to find out more information, for arthritis. And like I said at the beginning, I get to practice in a time where there are options for patients. So I just really appreciate this organization to be invested in that, and it will make an impact long term. So I just want to thank you.
Thank you so much. Well, we hope everyone
Thank you.
has a lovely rest of their evening.
Take care.
Thank you.